Hello everyone, welcome back to the series of lectures in nephrology. Today we will be discussing another very important topic, which is glomerular disorders. So let's begin. So in our first chapter we will be discussing about the basics of glomerular disorders and how do you approach your glomerular diseases. So before we move on to the diseases, we should be having a thorough understanding of the structure of the glomerulus, right? So the glomerulus is nothing but your basic functioning unit of the kidney. Okay, so the glomerulus is basically a tuft of capillaries. It is basically a tuft of capillaries. So it has a stalk, as you can notice here. It has a stalk and it comprises of a tuft of capillaries. So these tuft of capillaries are enclosed in a space. The tuft of capillaries are enclosed in a space which is called as the Bowman's space. So these tuft of capillaries are lined by what? They will be lined by endothelium. They will be lined by endothelium. Okay, so this is your Bowman's space and this, as you can see here, is your endothelium. Now the outer portion of the glomerulus that I am highlighting here has some epithelial cells which are called as the parietal epithelium. So this is your parietal epithelium. Okay, and these endothelial cells are present on what? They are present on a basement membrane. They are present on a basement membrane. Okay. Now, each glomerulus, which is a tuft of capillaries and it is composed in a Bowman space, comes and joins here at the stalk. And this stalk area has cells which is called as the mesangium. This is your mesangium. Okay. So, this is your basic structure of glomerulus. So, each glomerulus is nothing but a tuft of capillaries. Each glomerulus is nothing but a tuft of capillaries. Each of these capillaries are lined by an endothelium and which rest on a basement membrane. Then you have the Bowman space and the Bowman's capsule is surrounded by the parietal epithelial cells. Okay, so this is about the structure of the glomerulus. Now, so what are the hallmarks of a glomerular disorder? We have learned in a chapter on AKI that each of the diseases which cause acute kidney injury can be due to disease processes which affect each compartment. So it can be due to processes which affect the glomerulus, which affect the interstitium, which affect the tubules and which affect the vasculature. So we have looked at the tubules and interstitium disorders in our chapter on AKI. So this glomerular compartment, if it is affected, how does it present? So it presents with hematuria. It presents with hematuria. So what is the definition of hematuria? It is defined as more than 3 RBCs per high power field. More than 3 RBCs per high power field when you do the urine examination. But how do you know whether this hematuria is mainly because of glomerular disease or due to some other process? So hematuria can occur due to the presence of stones, it can occur due to the presence of tumors, right? So it can even occur in a lot of other conditions. So how do we know whether this hematuria is due to the glomerular process? So what you have to look for is the presence of this dysmorphic or crenated RBCs. Dysmorphic or crenated RBCs in your urine is suggestive of glomerular disease. What percentage? More than 40%. Okay. Apart from this, the hematuria which is associated with acanthocytes up to 5%, and the presence of RBC cast, the presence of even one RBC cast is significant and is suggestive of that the disease process is happening in the glomerulus. Okay, so this is your 45-1 rule for glomerular disorders. So more than 40% dysmorphic RBCs in the urine, the presence of acanthocytes and the presence of even one RBC cast suggests that this is a glomerular pathology. Apart from that, how do they present? They also have proteinuria. So we had briefly discussed about the proteinuria mechanism in your CKD chapter. So we know that there are podocytes which are present. The glomerular filtration barrier has podocytes and certain connecting proteins, right? So these are your podocytes. These ensure that this is your glomerular basement membrane. These ensure that what? They ensure that the proteins do not get leaked. So whenever there is a glomerular pathology, there is damage to these podocytes and you can have proteinuria. So urine albumin creatinine ratio more than 300 mg per gram or 24-hour urine protein more than 150 mg in 24 hours. So this suggests that there is a glomerular pathology. Okay. So what are the types of syndromes? So when you do a clinical approach to glomerular pathology, there are two ways in which these can present. It presents as a nephritic syndrome or a nephrotic syndrome. So it presents as a nephritic syndrome or a nephrotic syndrome. So what is nephritic syndrome? It is basically your glomerular pathology which has hematuria, which has proteinuria, but the proteinuria is less than 3 grams per day. It's not a massive proteinuria. Then the patient will have hypertension, patient will have AKI and oliguria. Okay. So what are the components of nephritic syndrome? It is a glomerular pathology where you have hematuria, proteinuria, hypertension, AKI and oliguria. Now how is it different from the nephrotic syndrome? Nephrotic syndrome has predominantly proteinuria where the 24-hour urine protein is more than 3.5 grams per day. So nephrotic syndrome basically comprises of proteinuria where the 24-hour urine protein is more than 3.5 grams per day. Apart from that, they have peripheral edema. There is not much of edema in nephritic syndrome, but in nephrotic syndrome you will have peripheral edema. Then lipiduria and hyperlipidemia. Then hypoalbuminemia. Hypoalbuminemia is also another very important component. Apart from this, they are also predisposed to thrombosis. Okay. So these are your major differences between your nephritic and nephrotic syndrome. So in nephritic syndrome, you have more of hypertension, hematuria, proteinuria, oliguria, AKI. In nephrotic syndrome, you can have AKI, you can have oliguria, but that is not part of your diagnostic criteria. So the highlight here is you have massive proteinuria of more than 3.5 grams per day. Hematuria is not a component of nephrotic syndromes. You have edema, hyperlipidemia, hypoalbuminemia and predisposition to thrombus formation. Okay. So this is how you see whether a person who is presenting to you with AKI or any of these clinical features is either having a nephritic syndrome or a nephrotic syndrome. I hope we are clear till here. Now let us understand our approach to hematuria more in detail. So whenever a patient presents to you with hematuria, patient says that he is passing blood in the urine, then you do a dipstick analysis. So this will be the first step. Do a dipstick analysis. If the dipstick is negative, then it is most likely due to porphyria. Porphyria is basically a group of disorders which occurs due to defects in the metabolism of heme. So defects in the metabolism of heme synthesis. Dipstick negative high colored urine is your porphyria. If the dipstick is positive, then you subject the urine sample to centrifugation. Then what you obtained is your supernatant. So if the supernatant is clear, that means what? The RBCs are present and the RBCs have settled down. That means it is a hematuria in itself. If the supernatant is not clear, despite centrifugation, that means this is either a hemoglobin or a myoglobin. Hemoglobinuria, where do you find that? You find that in PNH. Where do you find myoglobinuria? You find it in rhabdomyolysis. Okay. So every patient that comes to you complaining of high colored urine or passage of blood in the urine, this is how you will diagnose him. You subject the patient to a dipstick analysis. If the dipstick is negative, then it is porphyria. If it is positive, you centrifuge. If the supernatant becomes clear, then it is a definite hematuria RBCs. If the supernatant is not clear, then it is due to hemoglobin or myoglobin. So once you have confirmed that yes, indeed it is RBCs in the urine, then you have to see what the origin of your hematuria is. Is it a glomerular pathology, or is it due to any other renal pathology, or is it a urological cause like bladder stones or tumors? Okay, fine. Now to understand the glomerular pathologies in detail, we will have a clinical approach, a patterned clinical approach. So the glomerular pathologies can be divided into 6 different patterns based on their clinical presentations. So let us have a look at that. So first is your acute nephritic syndromes. How does your acute nephritic syndromes present? We have just now discussed. They present with AKI, oliguria, hypertension, hematuria, minimal proteinuria. Okay. So what are all the causes of acute nephritic syndromes? So this is your list. So in this list you can have a lot of overlapping conditions with other patterns as well. But this patterned approach makes it easier to understand what sort of a glomerular pathology you are dealing with. So PSDN stands for post-streptococcal glomerulonephritis. Then subacute bacterial endocarditis can present as nephritic syndromes. Then IgA nephropathy, ANCA-associated vasculitis, membranoproliferative glomerulonephritis, lupus nephritis, anti-GBM syndromes, and Henoch-Schönlein purpura. Henoch-Schönlein purpura, which is a type of vasculitis. Okay. So the first pattern is your acute nephritic syndrome, and these are the causes. Most importantly, you will have to remember PSDN, which is very common, IgA nephropathies, then your different types of vasculitis, and lupus nephritis. Then second pattern is your pulmonary renal syndromes. Second pattern is your pulmonary renal syndromes. So what is the characteristic hallmark clinical features in this? They have acute onset nephritic syndromes. It can be nephritic syndromes. They have a RPGN pattern, that means a rapidly progressive glomerulonephritis. Why is it rapidly progressive glomerulonephritis? Because within 2 to 3 days, they can have a complete renal shutdown. Okay. And what is the pulmonary portion? What is your pulmonary portion? They present with massive hemoptysis. They can present with massive hemoptysis. We'll be discussing each of these in detail a little later on. What is this massive hemoptysis due to? It is due to a condition called as diffuse alveolar hemorrhage. It's due to a condition called as diffuse alveolar hemorrhage. Okay. So what happens is that due to some inciting factor, there is damage to both the kidneys as well as the alveoli, as a result of which there is bleeding into the alveoli and they present with massive hemoptysis with worsening renal failure. So what are all the syndromes under this? You have the very famous Goodpasture syndrome, then certain ANCA-associated vasculitis, again Henoch-Schönlein purpura, and cryoglobulinemia. So this is your second clinical syndrome, which is your pulmonary renal syndromes. Third, nephrotic syndromes. So what are the diseases which can cause nephrotic syndromes? We have already learned nephrotic syndrome is albuminuria of nephrotic range more than 3.5 grams per day with hyperlipidemia, anasarca, edema, and a progression or a predisposition to thrombosis. Under this, we have the minimal change disease, focal segmental glomerulosclerosis. These are all changes which you obtain on a renal biopsy and do an electron microscopic examination. So these are the patterns of electron microscopic findings which you can find in these nephrotic syndromes. So minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, diabetic nephropathy, amyloidosis, Fabry's disease. The fourth one is your basement membrane syndromes. Basement membrane syndromes are very similar to your pulmonary renal syndromes because both of them can have basement membrane damage. But in basement membrane syndromes, you need not always have a pulmonary involvement. So there are certain other conditions other than maybe Goodpasture or your anti-GBM disease where you need not have a lung involvement. That is why they are classified separately as basement membrane syndrome. So this includes your anti-GBM disease, an inherited disorder which is your Alport syndrome, where there is an inherited deficiency in the collagen type 4. Collagen type 4. Okay. Then nail patella syndrome, thin basement membrane disease. So what are all the basement membrane syndromes? Alport, anti-GBM, nail patella syndrome and your thin basement membrane disease. Thin basement membrane disease basically refers to a genetic condition where the basement membrane becomes very thin, less than 360 nanometers in thickness. So what happens is that it's a fairly benign condition, but they can present with recurrent hematuria. Okay. Then the fifth syndrome is your glomerular vascular syndrome, where you have vascular involvement as well, predominantly your different types of vasculitis, which is your ANCA associated vasculitis, then APLA, antiphospholipid antibody syndromes, sickle cell anemia, hypertension, thrombotic microangiopathy, again HSP and cryo. And the last kind of clinical syndrome is your infection related glomerulonephritis. So different infections can cause glomerular diseases. So HIV associated, we have seen in your subacute bacterial endocarditis, infection related glomerulonephritis most commonly due to staphylococci, hepatitis B, syphilis, malaria, all of these can cause glomerulonephritis. So this is about the different patterns with which your glomerulonephritis can present. Fine. Now, how do you diagnose? So once you have identified that a patient is most likely having a glomerular problem, then how do you diagnose this? First is your urine analysis. In urine analysis, we have already discussed, you look for hematuria or proteinuria, and you also look for the presence of dysmorphic RBCs, and you look for the presence of RBC cast. The second step to always identify the etiology of your glomerulonephritis is to do a renal biopsy. So the second step is to do a renal biopsy. Once you do a renal biopsy, you study the sample under the light microscope. Then you do an immunofluorescence testing and you do a electron microscope study. So you can find out the patterns of glomerular injury and what exactly is happening to identify the etiology of the glomerulonephritis. So glomerulonephritis most often occurs due to certain antigen-antibody reactions to different portions of the glomerulus. Okay. So these antigen-antibody complexes can get deposited in any portion of the glomerulus and they give rise to different patterns. That is the whole point of why we do your renal biopsy, right? So these deposits can be in your, look at this structure, this is nothing but your glomerulus. Like we had discussed, a glomerulus is a tuft of capillaries. So this is your endothelium. The endothelial cells lie on what? This is your basement membrane and they are surrounded by certain epithelial cells. So these epithelial cells which stick on to the glomerular tuft is your visceral epithelial cells. Then you have your Bowman's space. This is your Bowman's capsule. And the cells which are found here are your parietal epithelial cells. Okay. So this we had already discussed in your anatomy or structure of the glomerulus. So if you take this portion, you enlarge it here, this is what we are looking at. Okay. So this is your basement membrane. Okay. So this side is your endothelium and your glomerulus, and this is your visceral epithelium. So this is your basement membrane, endothelium and your epithelium. So if the antibodies get deposited against the basement membrane, they are formed against the basement membrane and get deposited on the basement membrane, you get your anti-GBM disease. So if there are antibodies which are developed and formed against the glomerular basement membrane, they get deposited there and you find your anti-GBM syndromes like good pasture. So after your glomerular basement membrane, sometimes there can be antigen-antibody complexes which are formed and deposited in the subendothelial portion. Which type is that? That is your membranoproliferative glomerulonephritis. In your membranoproliferative glomerulonephritis. Then there can be deposits which can be found in the subepithelial region. In the subepithelial region, for example, in your post-streptococcal glomerulonephritis. Then there can be diseases which affect the predominant podocytes only. Podocytes are nothing but your visceral epithelial cells. If the podocytes alone are affected, podocytopathy, for example, is your minimal change disease. Okay. So based on these patterns, you can identify the etiology. So you have your anti-GBM, then you have subendothelial deposits in your MPGN, subepithelial deposits in your PSGN, then you can have a podocytopathy in your minimal change disease, and only mesangial deposits are seen, for example, in IgA nephropathy. Okay, fine. Now, once you have done this, you can also identify certain patterns on your immunofluorescence. So what do you do here? Here you do immunofluorescence to identify what type of deposits are present. Is it immunoglobulins like IgG, IgA, or sometimes complement depositions like C3, C4, C1q and so on. So if you get a linear IgG pattern, it is seen in anti-GBM disease. Right? If you get a lumpy bumpy staining or a granular pattern, this is seen in your other conditions where you predominantly have your deposits in the subepithelial or subendothelial, like your PSGN or your MPGN and so on. Okay, fine. So this is about how you diagnose your glomerular disorders and the patterns of deposition of your immune complexes. Now we have looked at what are all the types of glomerulonephritis, how do you differentiate between nephritic and nephrotic syndrome, and how do you diagnose based on your biopsy. Now let us put all of these together. So what is your approach? How do you approach glomerulonephritis? Now this patient has presented to you with oliguria, hematuria, hypertension and urine analysis showing hematuria or proteinuria. You have diagnosed him as nephritic syndrome, right? Or if the patient is presented to you with anasarca, hyperlipidemia and proteinuria in the urine, you have diagnosed him as nephrotic syndrome clinically. So the next step will be to do a renal biopsy and an immunofluorescence, right? So if the immunofluorescence is negative, you are dealing with a condition which is your post-immune glomerulonephritis, where there is no immune complex deposition. So that is nothing but your ANCA-associated vasculitis. Now the ANCA-associated vasculitis are of three types: GPA, which is granulomatosis with polyangiitis, EGPA, which is your eosinophilic granulomatosis with polyangiitis, and MPA, which is your microscopic polyangiitis. Okay, so GPA is a condition which is characterized by C-ANCA or anti-PR3 ANCA positivity. So how does it present? It presents with a rapidly progressive renal failure, right? It can present with ENT manifestations like recurrent sinusitis, recurrent otitis media or subglottic stenosis, and it can also have lung cavities, right? And it can also have some ophthalmologic manifestations including scleritis or a space occupying lesions in the orbit Now what is EGPA? EGPA, as the name suggests, is eosinophilic granulomatosis with polyangiitis. Okay. So what was GPA called prior? It was called as Wegener's granulomatosis, and this was called as Church-Strauss syndrome. Church-Strauss syndrome is nothing but eosinophilic granulomatosis with polyangiitis. So as the name suggests, it has eosinophilia with renal failure and mononeuritis multiplex. And what does it have? P-ANCA positivity. MPA, microscopic polyangiitis, also presents with renal failure. However, It does not have your nervous system manifestations, which is your mononeuritis multiplex, or your lung manifestations are rare. So 40% of the cases are C ANCA positive, 50% of the cases are P ANCA positive. So what are we discussing? We are discussing your post-immune glomerulonephritis, where your IF is negative, it is your ANCA associated vasculitis. Now if the IF is positive, you see whether this is a linear pattern or a granular pattern. A linear pattern is seen in your anti-GBM disease. A linear pattern is seen in your anti-GBM disease, and a granular pattern of immunofluorescence staining is seen in your MPGN, in your IRGN, post-streptococcal glomerulonephritis, and so on. And on the electron microscopy, depending upon the locations, we find out what type of glomerulonephritis you are dealing with. For example, if this is a subepithelial deposit, then this is your post-streptococcal glomerulonephritis. If it is your subendothelial deposit, then this is your membranoproliferative glomerulonephritis. If the deposits are predominantly in the mesangium, then this is your IgA nephropathy. Then you can have only podocyte involvement. If there is podocyte effacement, then you can see it in your minimal change disease. Okay. So this is about your approach to glomerulonephritis. In the next session, we will be discussing about each of these nephritic and nephrotic syndromes in detail. Thank you.